You start seeing elevated ALT, AST, just like we talked about yesterday, we have to start thinking, well, is this an infection affecting the liver? Is this a toxin affecting the liver? So something that's liver toxic or hepatotoxic. We talked about that yesterday at the end of the lecture. And then also autoimmune diseases. So some folks have genetic predisposition and autoimmune diseases that can affect the liver and affect the transaminases, right? The AST and the ALT, among others. Like I said, very testable topic. Lots always on boards on this topic. Hepatitis. Itis, inflammation. Hepa, liver. Well, it's inflammation in the liver. Three main categories I just told you about: infectious, toxic, and autoimmune. I'm mainly going to focus on infectious, but at the end, towards the end of the lecture, we'll talk a bit about toxic, but we'll get more into toxic in the next lecture when we start talking alcohol and fatty liver disease. And then the autoimmune will hit just briefly at the end. When we talk infectious, obviously bacteria, fungal, parasite, viruses is the big one we're going to focus on. And when you see the term hepatotropic viruses, that just means they're more prone to be liver-specific viruses, right? They cause specific changes, inflammation on the liver proper, in the liver cells. And then non-infectious hepatitis, we're talking drugs, which we hit a little bit yesterday. We talked about the big one, right, that folks go buy all the time and think it's very safe, Tylenol. That's the benefit. And then alcohol, we're going to spend an entire hour on, and then the autoimmune diseases. Those are your major causes. So the viruses, hepatotropic viruses, like I said, they specifically or mainly affect the liver. There's going to be some other systemic signs, symptoms, things we look for, but the big players, the most common ones in the U.S. are there. Luckily, they're in order: A, B, C. Those are the top three here in the U.S. of hepatotropic viruses that affect the liver. And then we have hepatitis D and E and G. And then G, we're not going to really talk about because it rarely causes any hepatitis, as it says on your screen there, on your slide. Biggest things to focus on as we go through each of the different hepatotropic viruses. You need to look at transmission. How do we get it? How is it transmitted between individuals? Is it fecal oral? Is it through blood, semen? Can it be passed maternally to a fetus? Then we look at, is it an acute only virus, or is this something that can hang around for a while and become chronic hepatitis? So some of the hepatotrophics have an acute phase and then a chronic phase, and that's when we start talking about the immunity markers to see if this acute infection has become chronic, because our body's immune system is going to make some specific markers to show us that, and we'll have to figure out based on signs and symptoms, and we're moving into more chronic hepatitis, which can actually lead to liver failure or cancer. And then lastly, how do we treat it? Based on the markers and the signs and symptoms, based on the serology signs and symptoms. All of the hepatotrophic viruses follow these four phases. Four predictable. Now the timeline that each virus stays in this phase in an infected individual varies. The incubation period can be short or it can be long. Same with the prodromal, where you start having non-specific symptoms, and we're going to hit each phase on the next few slides. And then the convalescence phase also varies between the different hepatotrophic viruses. So if you start seeing non-specific viral symptoms, you think acute, upper respiratory infection, acute GI, gastroenteritis, but then they get jaundice. That's when we start saying, okay, maybe we got to look at hepatitis or a viral hepatitis cause here. remember phase 3 there, that's when you start to have signs and symptoms. Icteric, meaning what? Yellowing, right? Usually the sclera of the eye first. So phase 1, viral hepatitis. This is all the hepatotrophic viruses, right? A, B, C, D, D, and G. We'll leave it in there, but it's not as common. So in this phase, it's viral replication. Your patient is normally symptomatic. So they've come in contact, they have a liver-specific virus, but they're walking around feeling just fine. Meanwhile, the virus is replicating in their liver and in their blood. You'll see often this referred to in the slide deck and on your boards. The replication phase equals incubation phase, right? Incubation period. Might be more familiar with that term. That means you're basically the virus is reproducing in the replication/incubation phase before you start to see any signs and symptoms. However, lab screening, serological values can be positive at this point. And we'll talk about when they're positive for each of the different viral hepatitis. But screening matters when folks are in this replication phase. Phase 2, prodromal. A lot of times, as I mentioned in our patient presentation just a moment ago, your patient's going to come in and you're going to go, oh, yeah, they got some kind of acute viral illness. They're just feeling not so great, a little tired, maybe some nausea, mild vomiting, arthralgia, so joint ache. So it sounds like the flu, right, really? So just some mild systemic changes. Urticaria and pruritus is common. So start having those wheals, those itchy inflammations on the skin. It's interesting in the prodromal phase, and for some reason the boards like to test it, but your smokers during the prodromal phase start to develop an aversion to cigarette smoke. I don't know why it matters, but it always comes up. I mean, I think most individuals have an aversion to cigarette smoke anyway, but specifically your smoking population during the prodromal phase of a viral hepatitis, all of a sudden they got to get away from cigarette smoke and develop an aversion to being around it. So now we move into the icteric phase for the hepatotrophic viruses. And in this phase, it's easy to remember, it's icteric phase, so yellowing of the skin you can see. So this is when you start to see true signs and symptoms pointing you towards a liver cause, either pre-hepatic, hepatic, or post, as we discussed yesterday. But they got jaundice, so we know something's going on that's affecting the hepatobiliary system. In this phase, you will see jaundice, as I mentioned, and then you start to have that dark urine as the bilirubin spill into the urine, followed by pale stools. Why? Because the liver is not conjugating the bilirubin, so it's not getting the color, normal color from the breakdown of the red blood cells and the bilirubin, because the liver isn't processing the bilirubin as well. So you'll get the dark urine, then pale stools in the icteric phase when you start to actually see signs and symptoms. This is your classic hepatitis progression, right? I traveled somewhere maybe, and then I come back feeling fine, starting to get some viral type illnesses, really non-specific, and then based on which hepatotrophic disease it is, we start to develop symptoms, and then we see jaundice, and we go, oh, now we have dark urine, then pale stools. This is something going on with our liver and our hepatobiliary system. In this phase, you might get some right upper quadrant pain. You might be able to palpate that liver now with hepatomegaly. You might be able to do a physical exam and note the size or enlargement of the liver. But still generally just feeling tired, run down. But now we're thinking, based on those cues of jaundice and the dark urine and then pale stools, okay, probably a hepatotrophic issue. And then the symptoms resolve, And if we're doing serological marking, which you normally do, right, you'll repeat those labs and we'll see a change in those markers. Well, AST, ALT going down, ALK, phos going down, everything kind of normalizing. But we can also draw some labs that says, hey, are we going to be a chronic carrier of this hepatic trophic virus based on if it's a viral hepatitis that we can become a carrier of, or do we have some markers in our immunity system, we draw the blood that says, hey, this is chronic, now we've got to treat this or else we could get liver failure or cancer. So once we get into convalescence, based on which type of virus you find out it is, and we'll talk about how we're going to do that, then we also, during the convalescence phase, want to look at clearance of the markers for acute infection and the presence or absence of markers in our immune system for chronic disease carrier or chronic disease active hepatitis. So start with A. A is good, it's the simplest, it's easy. Second most common in the US. There is an hepatitis A vaccine now. I mentioned that earlier in the lecture. So that's brought down the incidence, the occurrence. Hepatitis A, fecal oral. So when you start seeing your stem or your patient that's had maybe exposure to some contaminated food or water in an area that we know is a high population area for acute hepatitis A, travel to one of those endemic areas where hepatitis A is endemic. We see it a lot of times in daycares, an acute outbreak of hepatitis A. So your board cues are going to be recent travel and jaundice, think hepatitis A, right? Associated with local outbreaks, contaminated food or water, or travel to an area known to have it. In fact, for all you folks that are in the military, when you start putting in your leave to go to wherever, Ocomas, take a vacation to, you name somewhere, you'll have to do a little brief, right? An area threat brief. You'll have to read through it, and you'll see, hey, the area that you're going, we recommend getting the hepatitis A vaccine because it's a known endemic area. And then also our chronic liver patients, our cirrhosis patients, or chronic hepatitis C patients, we'll give them the hepatitis A vaccine to prevent the fecal oral transmission of Hep A. Like I said, always think about the route of transmission, and then we'll get further into like how it presents, the markers, and then does it become chronic or not. So A, easy, recent travel, fecal oral transmission, or those other couple of instances we talked about, daycare being a big one. The incubation period, also called what period? Phase 1 is what? Replication, right? Virus is in there making new viruses, making new buddies actively, but we don't really have signs or symptoms. It's about a month from when you come in contact with the hepatitis A, an individual eats something or has an oral input of hepatitis A, then for about 30 days, it's going to be doing its thing and replicating quickly in the body. So basically the time from exposure until we start to see the very first signs and symptoms, which is then moving into that prodromal phase, which we'll hit next. Virus is multiplying, usually asymptomatic, as I mentioned. They may be contagious at this point. Usually self-limited. There is no chronic hepatitis A disease. Say again, there is no chronic hepatitis A disease. Usually it's self-limited and will not become chronic. Low mortality, very rarely do we get any full disease, like severe infection of the liver and systemic changes associated with that. Unless you have all also your patient is co-infected with hepatitis C virus. And we'll talk in depth about C in just a few. What does it look like? Once again, viral illness. Viral, it looks like a viral GI, upper GI, or upper respiratory. So there's all your signs and symptoms, just general not feeling goodness, right? A little malaise, some nausea, and usually a low-grade fever. When that fever breaks, that's usually when you start to see the jaundice after that. That's your classic presentation I mentioned. And in this phase, this is when your smokers are going to say, yeah, I don't want to be around cigarettes. About 5 to 10 days of that low-grade fever, fever will break, and now onset of jaundice. A lot of times, these patients are diagnosed with a viral illness, like viral GI or URI, until we start to see the actual classic signs and symptoms of hepatitis, i.e. the jaundice. Now, once the jaundice develops, we do get the dark urine and then those pale or acholic, recognize that word, acholic, pale stools. Urine first. Then your symptoms are going to get a little worse once you start showing the signs and symptoms of the acute hepatitis infection. Then you get better. Usually this entire process for Hep A, a couple of weeks, 2 to 3 weeks. Self-limited, no progression to chronic carrier state. Lab findings, got a marked, elevation of AST and ALT. Bilirubin's going to go up because they're jaundice, right? ALK, phos will go up a little bit. The key here is that you're going to have anti-hepatitis A virus antibodies appear. Anti-hepatitis A virus antibodies, acute infection. What goes along with that to help you also validate that this is acute is that you get the immunoglobulin M anti-hepatitis A. You got the IgM anti-hepatitis A virus is diagnosed of acute versus IgG, which we're going to talk about a little later, which we don't usually see in Hep A. IgG is going to be that chronic infection. So however you want to come up with the mnemonic, however you want to remember it, you will see these questions about IgG, IgM. So for hepatitis A, it's immunoglobulin M anti-hepatitis A virus. Indicates your acute and current infection. Usually this is 5 to 10 days before the symptoms start when you can detect it. So it's in the replication phase. And you'll have that IgM anti-hepatitis A virus marker for about 6 months sometimes, hanging around. But the key is you can detect it in the prodromal phase. So definitely know that marker indicating acute hepatitis A is IgM anti-HAV. There's a chart for what I just said. And then, as I mentioned, the IgM is going to go up first, and then the IgG in chronic illnesses, if it develops, which is rare. Treatment, supportive. It's a mild viral illness that's affecting the liver. Bed rest if you need it. Antiemetics, antidiarrheal, fluids, regular meals, just like you do with any viral syndrome. Supportive. Do have your patients avoid hepatotoxic substances. Lay off the booze. Stop taking any of those medications we mentioned yesterday. So anything that's hepatotoxic while they're recovering from hepatitis A, then we want them to avoid it. The big thing there is the no alcohol. Avoid strenuous work and exercise. And then, as I mentioned, there is a vaccine. So a lot of times after these folks recover with their acute hepatitis A, then we do recommend the vaccination. All right, moving on to B. B is where the majority of your board questions are going to come from, because it gets a little confusing. There's a lot of serological markers that do lots of things. So I told you the key one on hepatitis A to look for an acute. In B, we're going to differentiate acute versus chronic, and when those markers show up. So I will give you the key ones that you need to know. You need to be familiar with all of the immunity markers for hepatitis B. However, I'm going to give you the key ones to differentiate acute versus chronic. So acute hepatitis B, blood sexual contact route. There is a perinatal transmission. If mom has the hepatitis B surface antigen detected, so the hepatitis B surface antigen, basically that's a protein on the virus itself. So if mom has the hepatitis B surface antigen present, she is actively or acutely or chronically infected and can be transmitted to kiddo. So earliest marker of infection appears before any symptoms here is the hepatitis B surface antigen. It's in the semen, it's in saliva, it's in vaginal secretions. Like I said, the surface antigen is on the surface of the virus itself. So you're looking at a protein that says, hey, this is here because it wouldn't be here unless hepatitis B virus was here, because the surface antigen is on top of the virus. So that's your acute, your marker for either acute or chronic infection. Unlike hepatitis A, hepatitis B can become chronic. Can be very mild hepatitis B infection, all the way to fulminant liver disease. The risk there is conversion of B into chronic hepatitis. Then we get some changes of the liver. We can get liver cirrhosis. We can also get liver cancer. High-risk groups for hepatitis B, well, obviously those working around fluids, right? Bodily fluids. IV drug users are a population that we worry about with acute hepatitis B. Staff at a hemodialysis center. IV drug users, as I mentioned, prisoners, and then all of us, healthcare workers, folks that are exposed to bodily fluids. You can do a screening for high-risk groups, and you'll often see that done, like when you start working in clinics or hospitals. Like you'll go down and visit occupational health before you start seeing patients, and they'll do a blood draw on you and rule out any kind of contagious viruses, including Hep B. Incubation period, very different from hepatitis A. Now we're talking 6 weeks to 6 months. You need to know that timeline. You need to know that incubation timeline. Hepatitis B, 6 weeks to 6 months. Average there for you, 3 months or so. And as I mentioned, if folks become chronic hepatitis B, actively infected chronically with Hep B, then you can get some cirrhosis. We'll spend some time in the next couple of days talking about how cirrhosis can lead to hepatocellular carcinoma. Incidence of chronic hepatitis B is higher in men than women. What does it look like? It looks like hepatitis A, just more severe. And then if it starts hanging around chronically, then we know it's not A. So we have those markers that we're about to get into that leads us to know if this is an acute hepatitis B versus A, or if it's become a chronic hepatitis B. Signs and symptoms, like I said, similar to hepatitis A, but a little worse. All of those mild symptoms I mentioned, a little worse. Labs, looks like A as well, as far as your normal liver markers, right? Our normal LFTs. If we have those elevated LFTs, we talked about those transaminases and the other ones that we can look at, AST, ALT, ALP, GGT, that whole list, right? So with acute hepatitis, as far as a LFT, elevated AST, ALT, but then we're going to get some serology, which we're going to talk about on the following slides, so look at immune response. The AST and ALT will be a little more elevated than you see with hepatitis A. Serology. So when you have an infection with hepatitis B, it's associated with very characteristic changes in serum levels of antigens and antibodies. And this was where it gets a little hairy, and I'll guide you through it, so don't get too stressed out when you see these charts. We'll talk about what you need to know off of this. Basically, why are we getting those serology markers? Because we want to know, we want to define for our patient what phase of the hepatitis B infectious process they're in. So first, the serological hallmark you need to know. Hepatitis B surface antigen. Active infection. If HB, little s, AG is there, obviously the HB is hepatitis B, so if the surface antigen for hepatitis B is there, that's an active infection. So where do we say that those antigens are? Like they're on the top of the virus. So we're picking up that, yeah, the virus is here because I see the surface antigen. Well, the lab's saying that. We see this and this amount. So we know it's acute. And then we also get in our hepatitis panel, so after you get your LFTs that are out of whack, and we start trying to run down the cause of the hepatitis, then we say, all right, it's time to get a hepatitis panel. So hepatitis panel is going to come back with all of these, and it's going to tell you what's going on in reference to A, B, C, D, and E, right? So acute infection, hepatitis B surface antigen, that lets me know hepatitis B virus is in this patient's bloodstream. Then we'll also get, after the patient starts to kind of clear their hepatitis B acute infection, now what will show up is the antibody to the hepatitis B surface antigen. So the anti-HBs. So what is it? It's the antibody to the antigen we just talked about, right? So now this is your cellular marker saying, we saw that virus floating around, so your body made an antibody against the viral antigen. So most individuals will start to clear the hepatitis B surface antigen. What does that mean? That means that the virus, through treatment, is being killed off and not in their system. So as the patient's clearing the surface antigen, which means clearing number of hepatitis B virus, of the amount of hepatitis B viruses in your system, then we're going to see that anti-HSB show up. So we're going to clear it with an acute infection, or if we give vaccines, it would look the same as a lab-wise, right? Because now we've exposed through a virus our body to the hepatitis B surface antigen, or a derivative of, so we make antibodies. So if you see the anti-HBs, so the antibody to the hepatitis B surface antigen, you're immune, which means you had it and the infection cleared, or you had vaccines for it. So that's an important concept, that the anti-HBs, antibody to the antigen, can either mean you had it and you cleared it, or it can mean we had successful vaccination. So you've got your doses. Now we can do a blood draw, and guess what? When you go to the occupational health clinic, before you start seeing patients, when they draw the panel, that's what they're looking for. Oh, you haven't had an active infection, or you haven't had a vaccine. So we need to get you on the vaccine before you can start working here around bodily fluids. Everybody clear on those two so far? Okay. Now we talk about the hepatitis B core antigen, HBCAG. Not going to be detecting it. So you can't see it in the serum. So if we say we're drawing a hepatitis panel and you see HBCAG, so the hepatitis B core antigen, that is a distractor. If you see that on board, because you're not going to detect it in a blood draw. It's inside the liver cells. It's in the infected hepatocytes. So if you see that hepatitis B core antigen, know that's a distractor. If the question is from a serological panel. Right, so then the hepatitis B core antibody, as I mentioned, it's going to appear after the surface antigen is detected during active infection, anti-HBC, predominantly IgM. So if you see IgM, anti-HBC, acute. You need to know that. Next to last bullet on the slide. So the IgM, so that immunoglobulin, M, that protein, antibody to the hepatitis B core, another sign of the acute infection of hepatitis B. And the IgG is going to show up later for patients who recover from the acute hepatitis B virus and those who progress into chronic hepatitis B. So the IgM comes before, during acute, before the G. However you're going to remember that. That acute is IgM, antibody to the hepatitis B core antigen, and then the IgG, antibody to HBC, is those who become chronic or recover. IgM anti-HBC acute, IgG anti-HBC past infection with recovery or chronic infection. Those two are huge concepts. So then we talk about hepatitis B E antigen. It's a protein that's derived from hepatitis B, but basically the E antigen just tells us if it's there, that virus is replicating a lot. Highly, highly contagious patient. So what hepatitis B E antigen signals high contagiousness in the patient. And then if it's there for more than 3 months, probably gonna become chronic. So hepatitis B E antigen indicating high viral replication and infectivity, which equals highly contagious patient. And the HPV DNA, so searching for the DNA of the hepatitis B virus, that's going to parallel hepatitis B E antigen. Everybody still with me? All right. Here's a chart. You need to know it, but here's what you need to know out of it. The stuff I just told you. Hepatitis B surface antigen, active infection. Anti-HBS, immunity. IgM, anti-HBC, acute. IgG, anti-HBC, past or chronic infection. And then the HBe antigen, high infectivity, highly contagious. So you got 3 charts you can look at. You need to be familiar with them, but those bullets that I've hit on the 3 previous slides, those are the immune markers that you start with, must know, have to know. And then kind of look at what goes along with it based on if you follow vertically down the chart, susceptible individuals. What does that mean, susceptible? Well, they haven't had any blood markers showing that they had a hepatitis, and they don't have the blood markers showing that they have immunity through vaccine. Then following it down, it'll tell you, hey, I got infected, so now I'm immune. So you should be able to pick that out of the lineup. Mainly the ones that shows that you had a past infection. The ones that say positive, but also kind of know what's negative. All the way down the list where I just mentioned already what shows acute, what shows chronic. Same chart, but now we're talking about the immunoglobulins. Remember the big takeaway, what comes first, IgM or IgG? M first, then the G. So hepatitis B surface antigen, active infection, as I said. Antibody to hepatitis B surface antigen immunity. IgM, anti-hepatitis B core, acute infection. IgG, anti-hepatitis B core is past or chronic. And then once again, HBeAg, hepatitis B E antigen, highly infective. So IgM anti-HBC on the board is going to be acute hepatitis B virus. And then if you see hepatitis B surface antigen plus anti-HBC IgG, chronic hepatitis B. Why is that? You need to know that, right? So what does the hepatitis B surface antigen tell us? Tells us the virus is in the system, right? Because it presents, think about it presenting on the exterior of that virus. So if the surface antigen is there, that means there's virus in the blood. So if I see that, but then I see that anti-HBC IgG, because IgG shows up after IgM. So if I have the hepatitis B surface antigen and the anti-hepatitis B core, IgG, now that's my chronic hepatitis patient. Everybody's following that logic, right? That if there's a virus there, and I got the IgG to the anti-hepatitis B core, well, that means you're still infected, right? It's a chronic infection because the virus is there and you're showing that delayed immune response with IgG versus the IgM anti-hepatitis B core is acute. There's a chart saying everything we just talked about on 3 slides. Most cases for acute hepatitis B, supportive. Severe cases, we do look for antivirals, right? And we'll talk about some of those in a couple of slides. There's just a couple of some classics to remember. Hospitalization if your patient develops encephalopathy or coagulopathies. Blood's not clotting right, or they're starting to have some changes neurologically. We'll talk about those signs and symptoms extensively, especially with alcohol liver disease. But if the patient is becoming more severe and they start developing problems with blood clotting, or they start having difficulty with neurological signs and symptoms indicating encephalopathy, now it's infecting the brain, that's severe disease, get somebody to admit that. Prognosis for hepatitis B, acute hepatitis B, clinically 2 to 3 weeks. Usually about 4 months for a complete recovery. I would know those 2 timelines, just like we said for Hep A. Prevention is vaccine. Also, what do? Blood is screened for your blood donation. Every time an expectant mother is going in for her prenatal checks, not every time, but at a certain time during those prenatal checks, they're gonna test her for that surface antigen, because it can be passed on to the embryo through mom's blood if she has the active hepatitis B surface antigen, as we said on the first slide of Hep B. Practice safe sex, because we talked about the transmission routes. Safe handling of all blood and bodily fluids or any contaminated materials. If patient positively diagnosed with hepatitis B, following it, we're going to give them the immunoglobulin. Hepatitis B immunoglobulin. Post-exposure, it's a series. But just know patient has hepatitis B or an exposure to contaminated blood, contaminated products, or if they, a partner, sexual partner calls and said, hey, I have hepatitis B, if you think you've been exposed, then we're going to get the hepatitis B immunoglobulin. Here's the chart. I've already mentioned it. Hepatitis B surface antigen, bang, there's a virus, and the anti-HBC IgG chronic hepatitis B. And it shows you the timeline there, which I give you to remember. All right. We're all good on Hep B. Hep B is the rough one, right? That's the hard carry. That's where, when I'm studying this, I'm putting a lot of effort into Hep B as far as the the antibodies and the body's immune response. Hepatitis A, pretty straightforward. B, that's where I focus on making sure I understand the body's immune response. Know the charts, know the tables, and I tell you this as someone who, when I initially learned it, I didn't really learn it. I memorized a few things to pass the test in the same class that you're sitting in, just somewhere else and many, many years ago. But then that first pants, every pantry, it shows up, and I'm like, I should have got that the first time. So get it the first time, so that don't be like me and miss that question on every board. So make sure you own that material. All right. Why don't we go ahead and take 10 now, and we'll get started back up. The next bit of the slide isn't on the slide, it's on his back. I actually didn't see that one. Yeah. Toes out from the shoe up. That's the protein. It doesn't show. And not that. That's different.
Halo was my jam. Like I can say it right now. I can
Very true. One letter.
That's what I did. I had like this little TV and I brought my lamp party so no one could see my screen. That's when I learned to do
Yeah. That means you had, yeah. That's an area. But that's why I made that. If that's research percentage, you can't be there unless it's right. That's a technical.
of the three shots. So that's why typically four because people were like, and then I get I love the delay. My favorite is when someone comes up with shores and like go around and typically, What I really like about that is you guys ever do the like bases that you like they take that actor and match, just like they make bases with just like beginners, all the way to like grab one that's like on the other side of the wall and lift through, and then like you move it, you have to make your way to the end. That endpoint was the skull, pick it up. It was fun playing all those crazy matches. I try to make it fun.
I'm not a cool person, so we're all dying. Yeah, you know, right? You want to fucking Halo up, dude. Yeah, I'm so down. Ooh, coming out for a child? But really, super hungry. You both make it. It's like 40 days. Yeah, actually, if you just buy each game, if you just buy the whole thing. If you just buy I'm down. I'm not a hater. Like, you got to know that that's a non-function. Like, this I am. You just mute yourself on the mic.
No. It's just gonna be like.
I get it. I brought it up. That's it. Let's go next one. I'll see you, bro. 40 bucks. There's no excuse. Nobody has an excuse. Yeah, dude. So gotta get the Mountain Dew, like with the Mountain Dew, eat it up. See what it is. Yeah, dude.
I think that down to like Doritos and
Pizza rolls.
yeah, I'll play this game.
I would be kicked off. I was so bad about that. Since that Mountain Dew, just get the fucking bar gone. Oh my god, dude. Yeah, that's what I'm saying. You're lucky. What is it? Okay. Mark's own comments. Me and my brother that's okay. That week, one of the days in the week, one night we had
I was trying to. That's the first game I downloaded.
oh really?
Play with your campaign. I think maybe play.
Dude, it's fun. Dude, if you play that, like, if she died however many times, it spawns on here.
All right, let's go ahead and get started back. So we can finish up. We'll be able to move a little quicker through the rest of the hepatitis. Not as much information to comprehend as Hep B as far as immune response, but still equally important. So moving on, now we're in hepatitis C. How do we get it? About half is from injectable drug use. So very common. It's blood exposure. Right? That's the route. We can also get infected blood transfusions for hepatitis C. You can get them in unsterile practices that do body piercing tattoos. If we have an unsterile clinic doing hemodialysis, we can get blood exposure to Hep C. You can get it from sexually transmitted infections, and maternal transmissions are possible, but both of those are considered low possibilities. Hep C is most likely of the hepatotoxic viruses that will become chronic. You need to know that. Hep C is most likely to become chronic. High risk of conversion to chronic state, and there's no vaccine. So different from hepatitis A, hepatitis B, no immunoglobulin, no vaccine. Significant increased risk for chronic state Hep C to move into cirrhosis or liver cancer. So I adopted this slide, but it is still in currents if you look it up today. I just thought it was a great statement. That covert transmission of hepatitis C during bloody fisticuff had been reported. So that's still in currents, which I thought was pretty amusing. Incubation period, 6 to 7 weeks. Often asymptomatic. We can get some chronic diarrhea, start to look like a viral infection, right? Mild. Often with Hep C, during acute phase, 6 to 7 weeks during that replication/incubation period, totally asymptomatic. Waxing and waning of the signs and symptoms, and then you get ups and downs of the AST, ALT, depending on those inflammatory cycles. The natural history of acute hepatitis B is either spontaneous clearance or it becomes chronic. 80% becomes chronic. It's a huge number. 30% of folks with acute hepatitis B or hepatitis C, 30% of the chronic hepatitis C develop cirrhosis. So 30% of your chronic hepatitis C patients, which are 80% that get the acute infection, then 30% of those will get cirrhosis. Those are pretty high numbers. Lab findings, so your LFTs, kind of similar to hepatitis A, hepatitis B infection. Here's a different marker you need to know for hep C. So the anti-HCV EIA. What is the EIA? Enzyme immunoassay, right? Enzyme immunoassay. So basically we can get, basically for hepatitis C, we do the anti-HCV test, and it's EIA. Kind of easy to remember. I'm worried about C. Well, I'm going to do the antibody hepatitis C virus EIA. Look at the blood and the urine. They do some magic chemical reactions, and if the color changes in the solution, voila, you have hep C. So if it's positive or equivocal, you need to know that there's 2 tests required. If it's there, then you do the HCV RNA. That's what confirms it. So you do a blood test for the hepatitis C virus RNA. That's the confirmatory test. You need to know that. That's a PCR. The HCV RNA. 2 tests required. And then if it's positive, you've confirmed this is hep C, obviously a full workup. Looking at a renal panel and UA minimal. Because we're worried about proteinuria, hematuria, or kidney failure, right? Our GFR starts going down. Much easier to get to the confirmatory for hep C than all the things you have to look at for hep B. Chart showing that, like I said, 2 steps, what you'll see. Treatment for acute hepatitis C. Start antiretroviral therapy as soon as you diagnose them. Are you going to be treating this patient? Probably not if you're a primary care. You're going to be referring this out to either IDs, infectious disease, or a hepatologist, somebody who specializes in the liver, right? Very high cure rates. That's why we have to treat our patients, because we talked about the large numbers that convert to chronic, and then the modest percentage of those chronic hepatitis C infections that can lead to further cirrhosis or disease of the liver. So how do we treat it? Direct-acting antivirals, DAA. That's oral. There's no injectable at this time. They're working on some injectables that are long-term, but you have to take a DAA. They're listed there for you. The Veers, right, usually are antiviral. You have to take them about 2 to 3 months, oral pills. Very, very high cure rates for the direct-acting antivirals, DAAs, but super, super expensive. Like that 8 to 12 weeks on DAA is about $100 grand. So normally, we're going to use the one that's cheaper, but doesn't cure as well, which is the second bullet. The pegylated interferon alpha 2. So just remember it as PEG interferon and the ribavirin. That's the one you're going to see usually used. And it still has a very high cure rate, just not as high as the DAAs. And it's much, much cheaper. It was probably, I mean, definitely in the amount of time I've been a PA, did we even have these, so it's been within the last 20, 22 years that we've even had this option. But before it was, oh, hepatitis C, many symptoms. There was no antivirals. I don't really know when they come into play, but it's recently. I mean, at least recently in terms of modern medicine. Clinical recovery from acute hepatitis C, typically 3 to 6 months. And then, like I said, up to 80% convert to chronic disease. And then 30% will develop cirrhosis, which we'll talk about at length when we start talking about hepatocellular carcinoma. Once you have cirrhosis, you have a high risk of hepatocellular carcinoma. Hepatitis D. This is a defective RNA virus. It only happens if you have hepatitis B. Can't have D without B. Usual route, we always say, kind of classically associated with IV drug use. Other routes similar to HPV, right? The bodily fluids and blood. Can only get it, and only get hepatitis D if you have concurrent hepatitis B, i.e. hepatitis B surface antigen is present, letting you know that that virus is in your system. And don't you forget, when I get to the end of this lecture, there's one table, someone pointed out to me at the break, there's one table, it's the third table on Hep C, where it says acute infection and it has a negative under hepatitis B surface antigen. If you have an acute infection, can you have a negative hepatitis B surface antigen? Absolutely not, because that means the virus isn't in your system. So thanks for picking up on that, and I'll go to the slide so that everybody's tracking. Everybody's got D. You gotta have B to have D. Hepatitis E. Well, that's usual. That's fecal oral. Like which other ones? What other hepatitis is fecal oral? A. So the top and the bottom of the list, those fecal oral. That's how I remember it. A and E. So consider this endemic travel once again to an area that's endemic with Hep E. Is fecal oral. The big take-home point for E is that expectant mothers, those that are carrying, pregnant patients, they get Hep E, high mortality rates. Waterborne outbreaks is how we're going to get it. Been to an endemic area, fecal oral transmission. It's mild to moderate clinical, just those viral symptoms. But when a pregnant patient gets hepatitis E, common progression to fulminant hepatitis, high mortality rate. You need to know that about E. All right, done with acute. I'm going to take just a moment to go back to that slide that was brought up before we move into chronic. I'll finish up the lecture. This one, hepatitis B surface antigen on the far left of your table. Just go down to where we say acute hepatitis B. There should not be a negative there. Should be a positive. Can't have hepatitis B without the surface antigen. That means the virus isn't there. So good pickup. I'll make sure I make that correction on the slide deck moving forward. All right. Chronic hepatitis. It's greater than 3 months, chronic. That's your definition of the timeline. Greater than 3 months is chronic hepatitis. That means your AST and your ALT is staying up, those transaminases. So persistent presence of hepatitis B surface antigen and the antibody, the hepatitis B core, or the anti-HCV. Obviously, the first bullet is for Hep B, HB, and then the next bullet, anti-HCV. So we talked about those tests at length. We talked about that they signify active infection in the past 3 months and they're still hanging around. Now guess what? We call it chronic. Or they do a liver biopsy during the workup and they look it under the scope and say, hey, this is chronic hepatitis. If your patient doesn't have concomitant cirrhosis with chronic viral hepatitis, either B or C, we're talking specific here, then they may be asymptomatic. They may not have any symptoms at all. So, chronic chronic viral hepatitis, the three things you're gonna pull out of it, right? More than 3 months. If it's B, know what the surface antigen and the antibody is present. And then for C, know what's present. Or, third option is biopsy. Timeline, immunomarkers, and then, or biopsy. How do we manage it? Well, the main goal for chronic hep B is to stop it from reproducing, stop replication. Secondary, if they're having symptoms, to reduce them. And you want to prevent progression to chronic hepatitis, which can lead to cirrhosis, which could lead to cancer. Ultimately, what's your goal? Preventing hepatocellular carcinoma for chronic HBV. Treatment for chronic HBV is antiviral therapy. And there's the PEG interferon again, like we talked about, for 48 weeks for the chronic HBV. So we mentioned it in hepatitis C. Now we're talking about it in V, and almost, just a few weeks short of a year. And the PEG interferon. And they can also have oral nucleoside or nucleotide analogs that are there for you. They end in beer. That means they're usually antivirals. So the take-home point is antiviral therapy for B, and then we talked about the DAAs. I think it's on the next slide. Option for Hep C. So the main goal for chronic HBV management, as I said, I'm sorry, that should say C. Top of that, the heading should say HCV. Main goal of treatment for HCV, I just cross out the B because we talked about B on the last slide. It should be C. Main goal there is same thing. Get rid of the virus, reduce symptoms, prevent progression, because we talked the large numbers that move to chronic, that move to chronic inflammation of the liver, leading to cirrhosis, which could lead to liver cancer. And then obviously we treat the extrahepatic complications if they're there. And then we talked about the DAAs on the other slide when we're talking HCV specific. New class, autoimmune. Is this a Hep A, B, C, D, or E? No, it's autoimmune. So there's no virus that's causing it. So it's chronic hepatitis due to autoantibodies. Primarily young women, and that often, if they're going to have autoimmune hepatitis, it's related to other autoimmune diseases. It's a clustering of autoimmune signs and symptoms. Varies clinically based on comorbidities or any other autoimmune processes that are taking place. Some discover it incidentally. Can be anywhere from feel fine, no symptoms, all the way to transaminitis, right? That inflammation of the liver with elevated AST, ALT, or LFT. Mild, non-specific, again, viral looking, fatigue, lethargy, malaise, anorexia, nausea, abdominal pain. A lot of, with liver inflammation, a lot of folks will get pruritus or itching of the skin. With the autoimmune hepatitis, we can also see some arthralgias involved in the small joints, like many other autoimmune disease processes that you probably talked about in ortho. So you get acute presentation of hepatitis and liver failure. It becomes severe, like that range from no problems whatsoever all the way to fulminant severe, with an acute severe presentation of autoimmune hepatitis. You're going to get liver failure possibly with profound jaundice, elevated PT, like bleeding marker, right? Marked AST, ALT elevation. Here's your extrahepatic manifestations, meaning it's not liver proper, but elsewhere in our system, right? Often associate autoimmune hepatitis, often associated with thyroid disease, Sjorgen syndrome. Have y'all had Sjorgen syndrome yet? Yeah, we should know it from ortho. And then arthritis, nephritis, so all extrahepatic manifestations of autoimmune hepatitis. That Coombs positive hemolytic anemia, which is autoimmune as well. So if you have fulminant or severe autoimmune hepatitis, then just like the other chronic viral infections of the liver, you can have an increased risk of cirrhosis and cancer of the liver. Just remember that autoimmune cluster, usually young females, and then these are the extrahepatic manifestations you'll see. Can be asymptomatic all the way to toxic liver. So that is it for the hepatitis and the autoimmune hepatitis. So I'm just going to change over. The memory jogs are loaded there in your slides. As always, please start there. Anchor yourself to the memory jogs. Check out the check on learning. If you don't understand why wrong answers are wrong answers, a little reasoning is there, but you need to go back now into the slide deck and put that together. And once again, on the check on learnings, it's just first order question, right? This is what? This is what? Some things bolded to pick up on. Test day, board days, you have to be able to pick those things out of a clinical scenario, which you all did fine on the block 1 test. So remember when you're studying, hit the memory jogs. It's not everything you need to know, but it will steer you towards everything that you do. All right, give me 1 second here to change over, and we'll get started on the next slide. All right, so part 3 is still hanging out in the liver. We're going to talk about non-alcoholic fatty liver disease, cirrhosis, and alcohol-associated liver disease. We're going to talk about basically the clinical progression of the liver when it starts to get infiltrated with fat, then gets inflamed, you get fibrosis or cellular changes, which leads to cirrhosis, which leads to lots of systemic complications. So basically you need to recognize the patterns of injuries and then progression. A lot of it's based on lifestyle. Also be able to recognize throughout the lecture if it's a life-threatening complication of liver disease. So non-alcoholic fatty liver disease, pretty straightforward. Non-alcoholic, you got fatty liver disease not associated with alcohol. It's defined as hepatic steatosis, so fat in the liver, hepatic steatosis, without secondary causes, mainly alcohol. That's why it's in the name. So there's a full spectrum of the non-alcoholic fatty liver disease. A lot of the slides show you there the 2 subdivisions. So non-alcoholic fatty liver, NAFL, simple steatosis, right? Just got some fatty infiltrates in the liver proper. Mildest form of non-alcoholic fatty liver disease. Then we look at NASH, non-alcoholic steatohepatitis. Well, now we have itis, right? So we have some inflammation in a fatty liver. That's worse, right? NASH is inflammatory, NASH is progressive, and it's the more dangerous form of non-alcoholic fatty liver disease. Know the categorizations of those 2 under non-alcoholic fatty liver disease. NASH is your dangerous one. It can lead to cirrhosis. Bless you. So non-alcoholic fatty liver disease as a disease process, strongly associated with being overweight, type 2 diabetes, hypertriglyceridemia, so high trigs in your blood. So obviously, if you got a lot of fats floating around in your blood, they can be stored in the liver. You get non-alcohol fatty liver disease. Insulin resistance. So is there any disease process, systemic cluster of symptoms that you've taught or been taught that kind of matches this a little bit, just happening in the liver? Have y'all talked metabolic syndrome? Right, so it's kind of metabolic syndrome of the liver, right, as far as the risk factors. Overweight, diabetic or pre-diabetic, insulin resistance, cholesterol panel and trigs out of whack, kind of like metabolic syndrome. If you see it on your boards or any test, an obese patient, they're diabetic, their LFTs are up, i.e. AST, ALT, what do you want to worry about? NAFLD, non-alcoholic fetal liver disease. That last bullet, studies showing increased association between NAFLD and gallbladder removal. How do they come in? Usually asymptomatic, and we find it incidentally, it being NAFLD. Some may report fatigue or vague right upper quadrant issues. Malaise, generally not feeling well, mostly asymptomatic. So it's early in the disease process. NAFLD, it's kind of silent disease, right? Nothing really presenting to where you should be worried about fat deposits into the liver. First thing usually that's going to show up is those transaminases, AST, ALT, ALT phos elevation. That's when we start running down the cause of it. Or we see it on imaging when we're doing imaging for something else. We're doing a CT of the abdomen for whatever reason, and they say, oh, there's evidence of fat deposits or steatosis in the liver. Key findings. We talked about yesterday briefly when we have to worry about AST, ALT ratios for alcohol related. But in non-alcoholic fatty liver disease, AST to ALT, 1-to-1. They go up, but in unison. And then your ALT phos would just be mildly elevated. So your AST and ALT, they'll be elevated, but they won't be in that 2-to-1 ratio. They rise universally or in tandem. Get an ultrasound, and you see hepatic steatosis, right? There's little deposits of fat that you notice on ultrasound. Definitive diagnosis is hepatic biopsy, usually not indicated. That's your definitive diagnosis, but usually not indicated. If you have NAFLD, you must rule out other causes of fatty liver disease. Always ask about alcohol. Every patient with any type of liver disorder, but especially NAFLD, have a sit down and a discussion about their alcohol intake. How do we treat it? Much like metabolic disease. Lifestyle. The things that you were doing were bad, do them more gooder. Right? Eat better. Diet. Exercise. We can give them some supplements, possibly vitamin E. If our patient is diabetic, we can talk about insulin sensitizers and let the GI folks handle that. But this is an important concept, right? This is one of the very few diseases which can be really bad that lifestyle modifications can completely reverse it, right? Can completely reverse the signs and symptoms of non-alcoholic fatty liver disease by changing lifestyle patterns, which is a huge concept. I mean, if we can, our only intervention is eat more gooder, do more exercise, take in less fat, avoid sugars. If we can get them to follow those lifestyle changes and be able to completely reverse the pathology, that's a good thing. Prognosis for NAFLD, it's usually benign. We can give those lifestyle choices and hopefully do with them, and over time, all those signs and symptoms get better. But not so much in folks that are elderly or diabetic, have a huge high BMI, greater than 30, or they won't adhere to our lifestyle change recommendations. Obviously, worse prognosis. All right, so that was non-alcohol fetal fatty liver. Now we get into the big guy, alcohol-related liver disease. Very similar progression, but a completely different course, right? Ultimately, it's chronic alcohol use, chronic excessive alcohol use. It goes through the 4 categories or stages below, right? So we get the steatosis, those deposits of fats, just like we had in non-alcoholic fatty liver disease. Then we get worsening with steatohepatitis. So now we got inflammation of the liver with fat deposits. And then we get full-blown hepatitis, and that stays around long enough to where we get liver cirrhosis. Alcohol drives the disease is basically the main difference between non-alcoholic fetal liver disease and alcohol associated, is that there's that association. 90% of heavy drinkers will get a fatty liver. 90%. A third of those will move on to fatty inflammation of the liver, so steatohepatitis. 80 to 20% of those heavy drinkers that got a fatty liver, which was 90%, 80 to 20% of those are going to get cirrhosis. So know that epidemiological process for alcohol-associated liver disease. Like I said, steatosis of fatty liver infiltrates seen in about 90%, and then about a third of those with fatty liver are going to get inflammation of that fatty liver if they keep drinking, and then 80 to 20% of those that have the steatosis will progress to cirrhosis. This is the phases. Like I said, know them. I won't have the picture on there, but know the phases that we talked about with alcohol-associated liver disease. So alcohol-associated steatosis, fatty liver, right? So if there's fat in there, what's going to happen is probably going to enlarge. So some hepatomegaly on exam. Usually your patients early on are asymptomatic. The LFTs are going to be elevated. And that key lab pattern down there again, it must be important in 30 lectures now, right? AST to ALT in that 2 to 1. And then what else are we going to say is highly associated with other liver function tests? GGT being positive, we're saying, okay, 2 to 1 with a positive, very sensitive marker, GGT, is alcohol related. If you see those markers in GGT, those things at the bottom, think alcohol. We can refer to ultrasound and biopsy if suspected, especially if you're starting to see signs and symptoms or complications leading to systemic liver failure or cirrhosis. It's just a cellular pattern of the liver with some fat deposits in it, not tested. Alcohol-associated steatohepatitis. So now, our fatty liver, we continue to drink, and it gets angry, right? Now it's inflamed. So we went from steatosis to this phase. Well, because it's inflamed, just like any hepatitis, we probably get what? Jaundice, right? Probably get yellowing of the eyes and the skin, depending on how severe. You can get a fever. Now that enlarged liver that was just fatty is inflamed, so it's going to be tender when you do that abdominal exam and find the lower order of the liver. Classic symptoms, no. When we move into steatohepatitis, we get the jaundice, anorexia, not wanting to eat, low-grade fever, and now our fatty liver is tender, so it's an ouchie, when it's palpated. Also get elevated bilirubin and elevated INR. Remember what INR is from block 1, farm 2? We're looking at coagulation, bleeding. We give medications for anticoagulants, right? And we look at INR to measure them. So basically, with alcohol-associated steatohepatitis, we can get some changes in our INR. It can be elevated, which means, well, we're not clotting well. And we already talked about the transaminase 2-to-1 ratio, showing up yet again. Other symptoms, more severe. Now we're getting from not so bad to more badder. Jaundice, fever, and now you got that tender liver. Labs we talked about. We can get muscle wasting as it starts to get more severe in the steatohepatitis phase. We can start getting that protruding belly, abdominal distension, and or ascites. Ascites is what? Like the fluid in the belly, right? It's compartmentalizing into the belly. Lab findings, we've said it enough. Bilirubin's elevated, right? Because they can have jaundice. GGT's up because it's liver specific. And now we know it's alcohol. We can have a leukocytosis with predominance of neutrophils in that leukocytosis. And we mentioned the elevated INR, which is international normalized ratio. How long does it take the blood to clot, right? So it's taking longer. Normally, Coumadin warfarin is what we're using it to monitor though. So always think when you see this cluster, right, if the patient's got some alcohol use, fever, jaundice, right upper quadrant pain, alcohol-involved hepatitis. How do we manage basically everything other than going to their house and pulling liquor out of the cabinets? We try to convince them to stop drinking, right? Convince them of absolute, total alcohol abstinence. They may have to seek out other help, right? They may have to go inpatient for some detox. They may have to seek out support groups. But whatever it takes to stop this progression before they have to be on the donor list for a new liver. Also want to talk to these people about nutritional support, maybe a nutritionist, to help them to recover from the nutritional deficiencies, which are many, right? I think we were on the next couple of slides. We get some anemias because of having a chronically inflamed liver. Obviously, if they're going to withdraw from alcohol, if they've been heavy drinkers for a long time, it's very dangerous for them to do cold turkey on their own. Can lead to death. Alcohol withdrawal is one of the bad ones as far as withdrawal goes. Obviously, we still talk to them just like with just normal fatty liver. Lose some weight, talk to them about the diet, obviously stop smoking, and then we can send them maybe to some CBT, do some cognitive behavioral therapy. Why would we, admit them? They're at the bottom of the slide. If you have like decompensated cirrhosis, i.e. you start to see hepatic encephalopathy, we're going to define that in a few, but I already told you something's going on neurologically in the brain, usually due to ammonia building up. They can move into respiratory failure, hemodynamic instability, or septic shock. Those are all folks that's going to need a team, right? An ICU team to work with them to get off alcohol. So the patients with severe symptoms from alcohol liver disease, about 34% mortality at 1 year developing cirrhosis, and then 85% at 5 years if they continue to drink. Only intervention that's going to make it 100% better, abstinence from alcohol. Usually, we're going to have to get a multidisciplinary approach. I mentioned all those other things that we can do. for us to treat and manage them. So now we were drinking, it was fatty, then it got fatty and angry, and now we're going into actual cirrhosis, the end stage liver disease. What is cirrhosis? So basically late stage hepatic fibrosis. So you get some architectural changes. These are changes in the structure of the liver proper. So distortion of the architecture, you get fibrous changes, also some vascular remodeling from the chronic inflammation. We get nodules that are forming as the liver tries its best to regenerate from all of the damage that's being done from the alcohol. And this can lead cirrhosis to portal hypertension. What does portal hypertension cause? Right, ascites. What about an upper GI bleed? Varices, right? And ultimately liver failure. Common causes of cirrhosis isn't just alcohol, but it's the #1 player. Chronic viral hepatitis. We talked about Hep C and Hep B and how they can become chronic and how we would treat that. If it's untreated, it can lead to cirrhosis. The non-alcoholic fatty liver disease, also not as big a player as alcohol related or alcohol associated. Also common cause of cirrhosis is hemochromatosis. We'll talk about that in another slide. And then classically we look at cirrhosis and put them in three buckets, right? Micronodules, they're tiny, they're at the cellular level, microscope looking to see them, right? Versus macronodular, you can see them with the naked eye, or you can't see through skin, so an ultrasound may show you nodular changes on the surface of the liver. The micronodular form, so the histological changes, most association with alcohol. So I would know the top three, I would know these three causes: alcohol, hepatitis B, C, or NAFLD, and we're going to talk about hemochromatosis further. The majority is the top three players there. 3 stages for cirrhosis. Basically, we're looking at the correlation of the thickness of the septae, the fibrous septae of the liver, making up the structure of the liver. So we can have compensated that then leads to varices, which we just talked about. And then we can have decompensated, where we start to get these classic signs of liver failure with ascites, that fluid in your belly. Variceal bleeding, we talked about that. Esophageal varices bleed, upper GI bleed. Encephalopathy, which is now neurological changes, and or jaundice. So those are basically the 3 stages of cirrhosis as those fibrotic changes progress in depth into the septae. So why do we get those clinical features? Usually dysfunction of the liver cells proper. And we also start to develop, due to the pressures, portosystemic shunting, right? So we start to develop alternate pathways for fluids because they're not going through the liver very well. And what does that lead to? Portal hypertension. Fluids getting backed up, trying to get into the liver and be processed. So that's why you get increased pressures, specifically for upper GI. We'll start to see those varices, major cause of upper GI bleed. So for compensated cirrhosis, usually just mild or asymptomatic, may have those, not feeling so great symptoms, just a little not hungry, weight loss, weakness, fatigue. That's early in cirrhosis and compensated phase, often in asymptomatic. Then we go into decompensated cirrhosis. That's when you see the classic liver signs, right? You're starting to see the yellowing, the jaundice, or the icterus, Piotaritis being that itchy skin, and then that's when you start getting into those emergency situations with upper GI bleeding, including vomiting blood, what's melena? Melena, what melena is? Those dark, tarry stools. As you got a bleed up in here, but as it transfers through the GI system, when it comes out the other end, it's dark and tarry, or either a massive upper GI bleed or lower GI bleed is metachesia, where you actually have bright red blood in the stool. Get an abdominal distension if you do get that fluid at that ascites, and then you can see your patient getting confusion when they get too much ammonia in the brain and they start having hepatic encephalopathy. So if you see fluid in the belly, i.e. ascites, the patient's confused, let's definitely start thinking about complications from cirrhosis. Jaundice, ascites, confusion, okay, what's going on with the liver? Here's a one slider showing you all the different things we can see with decompensated liver cirrhosis. So with that portal hypertension, fluid's backing up, so we start to get the ascites, which is pointed out to the belly there. Splenomegaly, enlargement of the spleen, as it's trying to now probably have a little collateral circulation and also trying to filter more toxins because the liver's not doing it. The caput medusae, we'll talk about that on the next slide with the definition. We already know what varices are. So there's a patient with the ascites, or a couple of patients. That muscle wasting you can see in the upper extremities. Gentleman on the left showing a little bit of gynecomastia, which can also happen. So systemic manifestations of cirrhosis, so decrease in BP. So patients with established hypertension may actually become normotensive or even hypotensive. The blood pressure starts to drop as a systemic manifestation of cirrhosis. Why? Because they're shunning all the fluids out into compartmentalizing in the abdominal cavity. The pressures that are intervascular are going down. You're checking the arteries there, right? But all the fluid in their body is actually, like in the last slide, out there in the belly. Patients get fatigued, fever, weight loss, muscle wasting. Once again, all systemic manifestations of cirrhosis. Hyperdynamic circulation. So this is what we see with our cirrhotic patients. It's usually initiated by the splanchnic and the peripheral vasodilation. So increased nitric oxide. So with that increased nitric oxide, what does nitric oxide do? Dilates, right? So there's another reason why that blood pressure may be actually going down as we progress through cirrhosis. So then we get a decrease in systemic vascular resistance, i.e. Arterial pressure is down. So we're not getting effective arterial blood flow, and we're also not getting the right flow through the kidneys. So that's why cirrhosis leads to kidney failure. We don't need to revisit the RAS. We hit that hard enough last while. And then we also get some renal arterial vasoconstriction, so we're going to retain sodium. So our excretion mechanism in the kidneys isn't working. So what happens when we have that decreased fluids and decreased pressure? RAS kicks us up, so you're going to see the heart rate increasing and trying to increase cardiac output. Just need you to know with the cirrhosis that we can get some systemic alterations of the blood flow, and then we start to see all these signs and symptoms of altered fluid dynamics. Ascites, being the fluid in the belly, you can get in the abdomen from cirrhosis. Obviously, enlargement of the liver that you can palpate, and it's usually an algae when you do, when it's cirrhotic, unless it's late in cirrhosis. The caput medusae, very pathognomonic. It'll be on your boards for cirrhosis. So you get that portal hypertension and the umbilical vein, which normally early in life, like it's gone, right? It's normal or ordinary in life is shut down. There's no circulation going through it. But when we start to get the cirrhosis and those fluid shuntings, that umbilical vein may actually open back up. So blood from the portal venous system, so from the veins taking blood away from the liver, can start being shunted through the periumbilical veins into the umbilical veins, and ultimately, that's how it gets into the abdominal wall veins, and then you start to see basically all of those lumpy, bumpy vessel or vasculature on the abdomen wall, which we'll show you here in just a second. And there's a specific murmur for systemic manifestations of cirrhosis there for you, the Prüfheiler-Baumgarten murmur. It's a venous hum. The patient has portal hypertension. Have y'all had that discussed at all? So that's a new one. So yeah, the CB murmur, the Prüfheiler-Baumgarten, venous hum oscillated in patients with portal hypertension. Usually stethoscope on the epigastric. So what would be the most dangerous complications of portal hypertension that we've talked about so far? Most dangerous, acute emergency. Varices, right? Acute upper GI bleed. Probably the most dangerous at this point, i.e. something has to be done right now or they die. Variceal bleeding. There's that caput medusae, and we talked about how it develops briefly, but basically we have some shunting of the blood with that umbilical vasculature that is opened back up, and now we've got fluid in all of the what should be small, not visible veins of the abdomen now are very visible on the abdomen. Other systemic manifestations, dermatological, so jaundice, we know what that one is. Spider angiomata or spider telangiectasis. You'll always see that associated with on your boards with cirrhosis. Those little spider veins on the skin, right? And the branches of spider veins. Palmar erythema is what it sounds like. You got some redness of the palms. There's some specific nail changes. The Murpney and Terry nails. Need to know those two. I'll show you them in a moment. But they're highly associated with cirrhosis. And then nail clubbing, which you probably already had, right? There's the picture of it where you start to get the convexity of the nail. When you're looking at the nail compared to the nail bed, it's convex. There's the spider angiomata. When you see it, you won't forget it because, yeah, okay, I got it. Spider legs coming out from those little point areas of vasodilation. There's redness of the palms, palmar erythema. There's the clubbing on the top left, the Terry's nails on the right, and then the bottom's the Murk nails. So basically with the Murk nails, there's transverse white bands. You see those white bands on all the fingers going across. You can't palpate anything there. It's just white under the nail, usually from low albumin. If you press on it, they do disappear. So we know it's pressure related. So when you press down on it, like if you're doing your cap refills, it's checked, those lines will disappear, but they return. Then on the right is the Terry nail, and the positive arrow sign is, see how white kind of ground glass appearance of that nail, and then the red arrow is actually pointing to that brown band at the tip, brown or kind of dark maroon band. The important thing is on both of these signs of cirrhosis, that as your nail grows out, they stay there. Versus, I mean, some folks will have little lines on their nails, then everybody's start looking at your hand, right? As it starts growing out, that'll disappear. And the same thing with Terry nails. If you have, whitening or ground glass appearance under your nail, as it grows, that'll move out, that'll go away. But with Terry nails and rip nails, no matter how long they grow their fingernails, it stays. Sign of cirrhosis. So now we move into systemic manifestations of cirrhosis. So women can have chronic anovulation, could have amenorrhea or irregular menstrual bleeds, and the men from cirrhosis can actually get gynecomastia, which I showed you on that picture. There's a better case in the slide deck here. Men can develop testicular atrophy from endocrine changes from cirrhosis. Also, they get some other signs of feminization often, and if we go back, when you're looking back through the slide deck, some of those folks that we've showed you with complications to point out ascites or the Poussey, you can also see that there's some other signs of feminization, loss of chest hair or any axillary hair. And then gynecomastia is the big one that's associated with systemic endocrine changes for males. And there's an example, this gentleman with cirrhosis that has gynecomastia. So head, ears, eyes, nose, and throat. You need to know that hepatic fever, sweet, pungent smell to the breath from cirrhosis. Sweet, musty, or pungent, like rotten fruit, it's often described. That's advanced liver disease. You can also get some enlargement of parotid glands due to fatty infiltration of those glands with edema and fibrosis. HENT, systemic manifestations of cirrhosis. The big one here for late manifestations neurologically is going to be that hepatic encephalopathy. What's going on here is ammonia is accumulating and folks are getting confused. Sleep inversion is a big indicator of systemic manifestations, neurological systemic manifestations of cirrhosis. Asterix is not pathognomonic, but it's in late cirrhosis. We often see it. Do you know what asterix is? Right. So exam, the patient. A lot of folks don't even have to be pushed on, but the patient extends their wrist, right? And then some folks automatically would just go into this beating clump that they can't control, uncontrolled, like flexion like that. But if you're suspecting it and you have the patient have their hands out like this, and then you as the provider push them more into extension, sometimes it takes that. When you pull your hand away, then it'll start that beating. It can be symmetric, but usually not. So no asterix is associated with neurological signs of cirrhosis. If you see asterix, it's hepatic encephalopathy until proven otherwise. That's pathognomonic. If you see asterix by exam or on observation, then that is hepatic encephalopathy association until you find another reason. Lab findings early, nothing, normal, minimal to no findings. And then later we can get thrombocytopenia due to splenomegaly. And then obviously bilirubin is going to go up, probably unconjugated, right? Because liver ain't conjugating anything in cirrhosis. Low albumin, low protein, elevated INR. We talked about that being a sign or a symptom of the chronic cirrhosis. So your clotting and bleeding time are increased. Can get anemias from cirrhosis. Folate deficiency would be the large cell type like macrocytic, or we talked at length in the last lot, GI bleed is going to, or GI blood loss is going to cause that microcytic anemia. If you're having any kind of infection, or if that spleen is enlarged, we can look at getting white blood cell count increased, or leukopenia from infection. So serum chemistry with cirrhosis, low sodium, increased BUN and creatinine, and that ammonia accumulation. What are we going to see on the liver panel? Well, fibrotic liver, so your AST, ALT is going to be up, ALK phos is going to be up, GGT is going to be up, bilirubin is going to be up, PT. So we have a thing, everything but protein's up. Protein's the only thing that is down or deficient. Every other thing in the hepatic panel with cirrhosis is going to be elevated. This is just a hepatic ultrasound, which y'all are gonna see, get to practice and play with in senior semester, and just showing there with the positive arrows that the liver on this ultrasound view, and you don't need to know this, it's not gonna be every test, you'll learn how to look at the liver with ultrasound next semester, but it's just showing that there's a nodular surface of the liver. We talked about those nodules for the liver trying to regenerate, and then also shrunken liver, smaller than it should be, and then you can see the border better because it's pointing out to the ascites or the fluid that's fluid there on top of the liver on the arrow more to the right. But like I said, you won't have that on this test. You'll see that next semester as far as ultrasound, which you do need to know the way that the liver changes, which we talked about, the nodularity, irregularity in earlier slides. We can get a biopsy, that's definitive. Do an upper EGD if your patient has portal hypertension. Why? Identify varices. Save their life. Identify it before it becomes an acute emergency. So that would be under other testing, that biopsy and the EGD. Make sure you know those two. Definitive to establish the histopathology with microscope, with biopsy, and then you look upper EGD for varices. Right, we're going to stop here under cirrhosis management, and we're going to get that finish up tomorrow with this deck. We got